The next speaker tonight is Dr. Noerine Kaleeba. The AIDS support organization in Uganda has become the model of AIDS support organizations right across the world. She also was a co-founder of UNAIDS with Dr. Peter Piot back in the early days, where she would be able to give more of her understanding, compassion and wisdom for the world to benefit from. She has multiple honorary doctorates and a knighthood. So there. Now, please, Noerine.
As an African woman, I believe that Father Michael, it did not just appear on the video just now. His spirit is with us here today. And that is why some of you who saw me during the day, I was dressed differently. But I wanted to go back and dress for Father Michael. I wanted to dress in the appropriate colors. I want to dress as an African woman. I wanted to dress as a Ugandan woman. This, what you see here, many of you will recognize, is the national dress for the Ugandan woman, a decent Ugandan woman. But I also wanted for us to say that this 1.5 hours we'll spend here will be special, because what we are going to reflect on are lives, some of who have been lost, many of who are living today with HIV, but many more don't have HIV. So that's what we are here about today. When I was asked to share some reflections with you today, I struggled with whether or not I should produce PowerPoint slides. And the reason why I struggled was really, at least in my experience, I have seen many PowerPoint slides. And quite often, when PowerPoint slides are introduced, you ask yourself a question: where is the power? Every time a new slide is put, you say, where is the power? And usually you don't find the power. Then you say, okay, where is the point? And very often, you don't find the point. But even after that long struggle with myself, I did produce PowerPoint slides. So I want to apologize right from the beginning. If you look for the power and you don't find it, don't blame me, because the power is with you. It's not within these slides. So don't look for the power in the slides. If you don't find any points, then blame Father Kelly. Because he's one of my mentors. He mentored me, and I met Father Kelly, and I'll come back to the story a little later on, very, very early in my struggle against prejudice, stigma, and restoring hope soon after my husband was diagnosed. These are my names. That's what this first slide says. Is there power in there? It just says, it just says that I chose to reflect, and base the reflections this is, how can we build resilience in order to overcome or challenge stigma? I'm going to share the power of humanity, the power of passion to overcome negative statistics. But I cannot avoid the temptation to share with you that despite our having led the world and having been acclaimed as the leader in openness, the leader in rights-based approach, the leaders in addressing stigma, in recent times, Uganda has taken a giant leap backwards by promoting a legislative process that has developed a list. And if you look at this PowerPoint presentation, I say the list continues. The reason why I want to bring this one up front is you will know that as a global community, I think many people are very aware of, I don't know how many in the audience are aware of the Public Assembly Act of Uganda, apart from the Ugandans. The reason why I wanted to start with this is increase the global community. How many know about the Anti-Pornography Act in Uganda? How many know about the Anti-Homosexuality Act in Uganda? Wow. How many know about the recently enacted HIV Prevention and Control Act in Uganda? The list continues. Now, the reason why I wanted to highlight this, and I hope we'll have some more space to reflect a bit more, is that Uganda has taken a giant leap backwards by developing draconian, totally unreasonable laws based on prejudice and stigma. And that's why we are focusing on stigma and prejudice today. Perhaps I should sort of say, those of us who live in Uganda and have been on the front line to support our legislators not to pass this draconian law, have been a bit disappointed by the global community in that, as you can see, the global community selectively picked the anti-homosexuality law. When Ugandans were struggling with the public assembly law, the global community. When Ugandans were struggling with the anti-pornography law, the global community. So the question, as a Ugandan living in Uganda, is why are we taking selective rage? Why can't we collectively rage against all these draconian laws which are threatening to undo our efforts? I don't know whether this shows beautifully. I wanted to tell you a story because I come from a storytelling tribe and nation. Where I come from, wisdom was passed from generation to generation through a story. This story begins with a wedding. I don't know if you see a wedding on this slide, because slides can show and sometimes they don't show. I see a wedding which happened many years ago, and the evidence that was many years ago, the picture was only able to be taken in black and white. This wedding happened at a time when there were no colored cameras. This is a wedding which has a bride and a bridegroom. The bride is this one standing before you. Although the bride in the picture looks much younger, much happier, and a little less rugged. This is the story of Christopher Kaleeba, my late husband, who I was married to for 15 years. And in at the bottom picture is the story after 15 years after being diagnosed with HIV. And the picture is the day he returned home to Uganda, because when he was diagnosed, he was living in England. He had gone to England to pursue his master's degree studies and had actually completed his master's and was working on his PhD when he collapsed and was taken to hospital and was diagnosed with AIDS. This is in June 1986. At the time, I was the principal of the School of Physiotherapy, one of the most senior health workers in the hospital. I had never emotionally addressed myself to the issue of HIV or AIDS. I had heard about AIDS. But what I had heard about AIDS was selectively, that was a disease that affected white, homosexual men in San Francisco. But because I had never been to San Francisco, I had at that time never met a white homosexual man. I had selectively dismissed AIDS from my life. So when I was told that my husband had been diagnosed with AIDS, my first instinctive reaction was denial. They had surely have made a mistake. It can't be my husband. I am Catholic. I was married in church. We have 4 children. I have never had extramarital relationships, because despite the fact that I had heard about it being a white homosexual men's disease in San Francisco, increasingly in Uganda, we had heard that this disease was also affecting promiscuous people in Kasensero. Some of you who have studied the story of Uganda, the border between Tanzania and Uganda, and that this disease was selectively affecting those that were promiscuous, or the soldiers that were returning from the Idi Amin wars from Tanzania. That was my story, despite the fact that I was a health worker. It's a long story, and we can't finish it in this space. What I thought I would share with you was what I term the pillar of resilience. I think you have heard towards the end of Father Kelly's intervention that what we actually set out collectively as a humanity to do is to explore how we can strengthen our resilience in order for us to survive the AIDS pandemic. And I'm not going to go through this slide because many of us have had, some of us have, but others haven't, had opportunity to define resilience. But what I would like to say on this particular slide, resilience means that you can be bent, but not broken. I hope by the end of today, we can convince ourselves that we can help our people, we can help each other, we can help ourselves first to be resilient, to be able to be bent by diverse challenges. And this story is about HIV, but it's a story that can relate to the many multiple challenges, the Ebola challenges, and many more that will come in our midst. And I keep saying, today I was talking to another one of my inspirational mentors, Jens van Rooij. I was saying that this pandemic has devastated many of us. We have lost loved ones, but has also given us so many opportunities as a human race. And one of the key opportunities is the opportunity to build our resilience. I will go through very quickly these slides because I hope they will be available to you afterwards. But I wanted to highlight on this particular one these 3 pillars of resilience. And those of you who have academically gone through these issues that I'm talking about will have different versions of the story. But the ones that I can testify to that were critical, ones that we must now focus our efforts to ensure that we build, that individuals are able and assisted to identify the I am. I am. And they must be assisted to identify the I have and I can. Now, these three pillars are ones that we, in the story I began to share with you, identified very, very early, and we grabbed on them. And we constituted and constructed a process and a package of counseling and awareness building to enable people to challenge stigma. On this slide, I try to zero in on this I am pillar of resilience because it helps you to identify your roots. I remember during our early days reaching out to those people. One of the very devastating and prominent features of AIDS diagnosis when AIDS first came to my house was the feature of rejection and devastation. I, as an African woman, had never experienced a situation where a person is ill, the family brings them to the hospital and leave them there. Because many of you who are very familiar with the situations in the hospitals in Africa, when I am ill and I get admitted into hospital, I need my family. Quite often, sometimes, some of you who go there for the first time, you get very frustrated because the hospital ward is full of human beings. And in some cases, in some rural areas, even the chickens and the goats are brought into the hospital. Now, you can look at that process as a negative manifestation of backwardness. But when I saw for the first time people being brought to Mulago Hospital and being abandoned there, the people that we first supported and cared for as TASO, a support group, had been abandoned by their families. And when you would ask the young man or young woman, where is your mother? Where is your sister? The answer would be, I don't know. They brought me here and they have never come back. And for me, it was the first disease that I ever saw that manifested that way. These efforts were what climaxed into what is known as TASO Uganda. This was a spontaneous initiative by a small group of people, including my husband and I, who responded to a crisis that was around them. Today, when you ask people in Uganda, they will have their various explanations of how TASO came about. Some people even believe that TASO is a government program. It is one of the most successful government of Uganda programs that was set up to address the plight of people with HIV. Or it was one of those things that Noerine sat down and wrote a strategic plan and got funding from whoever, and then to help them. Very few people, Ugandans, remember that this was a spontaneous support group. We found ourselves in a situation where we had no support for ourselves. We wanted to support each other and to cope and to educate our families and to educate the healthcare workers. My own experience, which is published in a little booklet, which is AIDS in the Family, We Miss You All, is when Christopher came back from Castle Hill Hospital. I did say that he was diagnosed while studying in England, and he was in hospital in England for 3 months before he asked to be discharged to come back home. And when he came back home in Mulago Hospital, we were admitted on Ward 6B, and the entire time between November 18th, when he was admitted in Ward 6B, until the 23rd of January 1987, from November 18th, 1986 to the 23rd of January 1987, during that entire time we were in Mulago, he was never touched. by a doctor. And the medical team would come and put their hands behind their backs and inquire. It was like the Ebola situation that we are going through today. So it was a desperate attempt for us ourselves to find support for ourselves. And we were inspired by Christopher, the way, however short his life was, because he was diagnosed in June 1986 and he died in January 1987. That short time gave us the contrast between the tender, loving care which he was cared for at Castle Hill Hospital, where he had been in England, and the treatment that he was awaiting him when he came back home. It also energized my family to give example to other families of solidarity. Today, I look back and thank God that HIV turned out not to be as contagious as Ebola. Because if it had turned out to be, then the entire family, including my 4 daughters, would have been infected. Today, as I stand before you, I can say that Christopher died of AIDS. I did not catch HIV from him. At the time, it wasn't, and the subject of discordancy wasn't understood. And I spent many years wondering and hoping beyond hope that I would live longer to be able to do something about HIV before I succumbed to AIDS myself. Those many years are a bit difficult for people who are operating in the AIDS arena today, because a question would be, but why didn't people take medicines? Medicines were not there at the time. And what we had to sell in building people's resilience was a commodity called health. Health in the sense that we were able to focus on treating the opportunistic infections and enable people to be able to eat, enable people to regain their strength, and building on the resilience that we had been building through counseling, we were able to build hope, we were able to restore dignity, we were able to influence the attitudes of healthcare workers to look positively and do their work positively. And we were able to adopt a slogan which today remains true for TASO: positive living. If you look, and the way we did it is by providing counseling, by building compassion, by reconstituting families, those families that had gone astray, by developing new support systems, by strengthening the little bits of threads of support systems that had been, and we were able to restore in people's minds, and I'm talking about before ARVs were available, we were able to influence that people lived positively and were able to die with dignity. The work then, after we were able to restore the individual human to get their resilience and address the stigma, including self-stigma, and get hope, then the challenge remained at workplace, because people were going back to their work. One of the joys of my life was not in Uganda. When I left after 10 years and I took my job with the UNAIDS core team, when I first arrived in Geneva, one of the first opportunity I sought was to find people in Switzerland, in Geneva, living with HIV. So I looked for hospices, because some of you know that in Europe there were hospices for people with AIDS, and I attached myself to the hospices. And did he show yellow or red? One of the joys was that arriving in Geneva 1995, and I would go to the hospital and interact with people with HIV, and I would take people to the park. But being in Geneva, and towards 2000, the hospices were closing. People were going back to their work. Equally, even in Uganda, where even ARVs hadn't become a reality, through positive living, positive hope, dignity, people were going back to work. So the challenges began to be fighting stigma in the workplace, people going back to work. So we developed a package which I had the intention to go through with you today, which today I feel that is one of the biggest unfinished business. Because even as people get better, the challenges that we have, now I'll speak about Uganda, is there is no work for people that are healthy and are getting better and are going back. That's one. There is continuing stigma in workplaces where people are going back. There is continuing stigma in schools because we are now faced with a situation, children who are born with HIV are at secondary school, are at university, and are having to take medication, are having to grapple with the relationship buildings. You know, these are teenagers, they are dating, and they want to be dated, and they are having to take medicines amidst continuing stigma. That's a very, very important continuing challenge. So, I say, this is the last slide, we have to remain resilient and be resourceful. Those of you who have been to Uganda, this mode of transportation is my favorite. But as you can see, this lady is resourceful. I think this actually appeared in one of the daily newspapers. And this lady was leaving her husband after persistent gender-based violence. We heard about gender-based violence today. And she wasn't leaving anybody behind, not even her jerrycans. But you see, resourcefulness, we have to be resilient, we have to be resourceful, but as we are being resourceful, we have to be safe. I want to go back, finally, as talking about resilience and resourcefulness, and share with you very briefly that in Uganda, we are walking a very delicate balance, especially now that our leaders, in their wisdom, have decided that HIV will be resolved by laws. Let's legislate this HIV out of the system. The HIV Prevention Act that was recently signed has very progressive and very beautiful provisions in it. It provides, for example, for the first time, we have a law that requires government to provide treatment for its people, that requires government to provide funding for the AIDS prevention programs that are, until now, have been considered as exclusively donor-funded programs. So that act, for the first time, provides for most of that. But it has clauses in it that threaten entirely all the work that we have done over the last nearly 30 years. It has an intentional transmission. I think many of you have heard about countries that have put intentional transmission clauses in their law. Uganda has joined the club. Intentional transmission that puts particularly the lives of women who are struggling to keep themselves HIV free, but more importantly, are struggling to keep their children, those that are HIV infected, are struggling to keep their children free of HIV. Because the law punishes the person who has knowledge of their serostatus, this clause threatens to stop people from going for HIV testing. Because if I don't know my status, when the court case comes, I have nothing to be judged against. The law, the anti-homosexuality law, threatens to drive a minority of Ugandans and underground. It threatens those organizations that have been bravely able to provide services for anybody, regardless of sexuality. It threatens for these organizations to be closed. It threatens not only just the dignity, but also the gains that have been had in stopping HIV transmission. The anti-pornography law has many provisions, but the majority of the provisions are against women's bodies. The law defines what you can wear and what you can't wear. It defines the length of your skirt. Every day you are supposed to be covered up in a suit like I'm dressed now. You can't show your tits. So I want to end there because if I don't, I'll be in big trouble. Thank you, and I hope this has stimulated some discussions in your heads so that you can see how we can help each other to fight stigma and defeat it. Thank you.